Welcome to the inaugural seminar series from the newly formed Mental Health Innovation and Improvement Series, which which I formed very recently to focus on trying to help with the weight gain and the physical health issues that people have when they take antipsychotic medication. This network arose as a direct result of the research that I've been doing recently on the Resolve project, which has investigated the experiences of people living with antipsychotic related weight gain. And one of the big things that I kept being told from staff was that they don't have the cross network. So quite often people working in mental health units don't have access to people in, say, dietetics, and that as a general feel, you don't have the skills, knowledge or experience to necessarily deal with not only weight gain, but the physical health challenges that people face. So we've set this network up primarily to help bridge that gap. And one of the things that we will be doing is providing monthly, 10 a year. We won't do one in August, and we might not do one in December, although we do have one planned for this December. But we'll do a minimum of 10 a year of these seminars that we will record and put on a YouTube channel. Now, Lauren will put the link for the YouTube channel in the chat. So if you want to, if you're not able to make one of these in person, but you want to be able to log in afterwards, then if you subscribe to the YouTube channel, you will get a notification as soon as the seminar is uploaded. That's the way, that's the best way. The other way to communicate with us. So I know a lot of you have already joined the network via the JISC mail. And we've had a ton of people from CNTW, so up in the northeast, and we've also had a ton of people from Berkshire. So I'm guessing that somebody in those particular trusts has shared this with the internal trust network. So if people are from other trusts and wish to widen this out to the people that they know, then please do feel free to share. And again, I think Lauren's just put the link in the chat for if anyone is on this call but not a member of the JISC mail group. Now, just a very quick discussion about the JISC mail group. So it's a way for us to be able to communicate with you and for you to communicate with each other. You can email. I think it works on a very similar platform to NHS Futures, but as I'm not in the NHS, I can't see that. I'm just working on what people have told me. You can ask people questions. The idea being that there potentially are people in the country who have done something that you might want to do and might be able to offer you some help, advice, or be able to give you essentially a blueprint of something they've already done that you can adapt for your own trust. So I'm hoping that this will be a cross-disciplinary network, because a lot of these networks that do exist tend to be in particular disciplines, so siloed. So please use that email to be able to communicate with each other. If you find that the email, the volume of emails that you're getting is too much, you can log into your account on JISC mail and you can alter the frequency. So you can ask to receive every email that's sent. I think you can have a daily digest, a weekly digest, and I think you can even have no digest. So this is up to you. So you can log in and choose those parameters. It does mean that if you have daily digest, that if you will get every person's question and every person's reply. You can choose to read them or ignore them as you wish. So I think that's probably enough around what it is we're trying to do, but I'll just very quickly tell you about myself. So my name is Jo Howe, and I'm currently working. Sorry, we've just had the post arrive, and my dogs don't like the post. I'm currently working at Aston University, and I've been working in the area of mental health research now for over 3 years. I've been looking at, sorry, I'm just going to go and get the post from the door. Okay, thank you. Sorry, you'll probably see my two little dogs walking back in. Come on, in you come. Post is not allowed to sit in the letterbox in our house. Come on. So I've been working in research looking at the side effects of medication, particularly antipsychotics. And our research has just recently ended, and that can be a future program of one of these seminars for you. Sorry, I've completely lost track now. I'm a chartered psychologist by background, but I'm currently working in pharmacy school, so I've got a very close relationship with a number of pharmacists as well. And the other person who is set up this network and leading it with me is Dr. Ita Fitzgerald. So I'll let Ita come on, and hopefully she'll be a little bit more eloquent introducing herself, and I'll sort out my dogs.
But I'm not sure that I will. I'm going to apologise for my voice, just if I have to talk now or later. I have an awful cold. I am here in Dublin in the Republic of Ireland, and I don't think Ireland has realised that it's supposed to be summertime as of yet, but here we are. So hi everyone, my name's Isha, as Joe said, and I am actually an advanced specialist pharmacist in mental health here in the Republic of Ireland, and work currently as a clinician and as a part-time researcher as well. So I would have met Joe and been introduced to Jazz as well, who's going to speak today based on some work we've done together on managing antipsychotic induced weight gain. So my program of PhD research would have been within that area, and something I would have focused on a lot is the biological mechanisms of antipsychotic induced weight gain and pharmacological management strategies. So just to say before we hand over to Jazz, I imagine it may come up today around questions around managing antipsychotic induced weight gain, particularly for the fellow pharmacists or other clinicians who join us. But we are going to talk about that in our next talk, which I think is the 30th of July, if I've gotten that right. And I'm going to cover that then, where we're going to primarily focus on the use of GLP-1 agonists in managing antipsychotic induced weight gain. So I'd encourage everyone to join that. There's been a lot more research in it recently. So we're going to discuss that in terms of its evidence base, some of the risks associated with these medicines, as well as their benefits, and really, I suppose, overall, where they fit within a management algorithm for both the prevention and also the treatment of antipsychotic induced weight gain. So if people have questions around that, please join us on the 30th. Be more than happy to address those. And also in terms of using the GISC mail or the channel, if people do have specific questions around GLP-1 agonists, we're all really keen to make these talks really practical for the people who are attending and who are working with supporting this cohort of patients. So if there's stuff that you would like covered within that talk, I would love to see it. So please comment here today or use the GISC mail for that purpose. So with that in mind, I think we might hand over to Jazz, Joe, to get started, if that works for you and Jazz.
Yes, of course. Hello, hi.
2 seconds, Jazz, before you start. I'm just sorry, I was speaking but on mute, so nobody could tell. But what I was going to say is, whilst Jazz is speaking, if anyone's got any questions, if you put your questions in the chat, I will come to you in turn at the end of the seminar, and then we can make sure that we can put questions together that are very similar, if that's okay. And what I will say is I hope you enjoy it. Like I said, it's already being recorded and it will be uploaded within a week. Lauren, if you can have a look for the link for Ita's chat, if you could put Ita's talk, if you could put that in the chat, and then later on people can register for that as well. So over to you, Jazz. You're now on
Sorry.
mute.
No, I did exactly the same. I left myself on mute and started talking. Hello, thank you very much, both Ita and Joe, and Lauren, and everyone else who's here on the call as well. So yes, I was asked by Joe to basically think about giving this talk about understanding the mechanisms that kind of drive antipsychotic induced weight gain. Just to give you some information about myself. So I'm Jasleen, I'm also known as Jazz. I am an academic clinical fellow, so I work 75% of my time in the Black Country Mental Health Trust over here, just north of Birmingham, and then I spend another 25% of my time sort of researching for the University of Aston. So I too am a part-time researcher. So I'm still quite junior within my training. However, it has been an incredibly insightful journey. I've had the opportunity to work with both Joe and Ita and Lauren on some of the work that was being done as I joined the team, actually. So just to dive into the talk, I've tried to keep it kind of quite simple and just the basics of sort of antipsychotics. What are they? And obviously we all know what they are, but also the mechanisms that kind of come out as a result of using these medications and how it impacts weight gain more than anything. So just a really quick overview. So in today's talk, I'll just be giving quite a quick overview of antipsychotics, comparing first and second generation antipsychotics, thinking about sort of the mechanisms that drive this kind of weight gain, comparing different antipsychotics, and then later kind of going into the more details of what kind of mechanisms or ideas that we have that we think drive this weight gain, and then considering kind of the long-term impact of antipsychotic induced weight gain, and then kind of considerations regarding the future as well. So, as we all know, antipsychotics are used to treat a variety of different conditions. So, you know, I've just mentioned schizophrenia here, but, you know, there are a variety of different uses that we end up kind of using antipsychotics for, you know, as well as psychosis, as well as, you know, I'm sure we've all come across patients who perhaps have personality disorders and are put on antipsychotics as well. So, it's, you know, we all know that these medications are incredibly effective at what they do. And I'm sure that we're all very aware that a significant side effect of using especially atypical antipsychotics is this kind of weight gain that we observe. And a lot of the time what happens is that this weight gain varies and is dependent on sort of how this medication acts on different receptors. So I've listed over here kind of serotonin, serotonergic, dopaminergic, cholinergic, and histaminergic kind of system. So we'll be looking at that a little bit later. And I'm sure we're all aware that actually this weight gain that happens as a result of patients taking these antipsychotics that manage their mental health incredibly well, but cause this weight gain can kind of lead to a lot of distress within patients, and lead to a lot of unhappiness, can sometimes even lead to a deterioration or further kind of worsening of mental health. And can eventually lead to kind of a discontinuation of the medication, which can then eventually lead to relapse. So it's quite an important area that we're kind of exploring. And we're also aware that obviously patients with severe mental illness, you know, have a higher rate of premature mortality compared to the population. We know that on average, they live sort of, you know, about 5 to 20 years less than the rest of the population. So that is quite a stark figure to be dealing with, actually. So one of the things that we were thinking about is that if we can then tackle this weight gain or antipsychotic induced weight gain, perhaps maybe we can help improve that figure and improve that life expectancy. Forgive me if you already know this, but just I thought it'd be important just to go over again, sort of comparing kind of first generation antipsychotics to second generation antipsychotics. So there was quite an interesting table I found. So first generation, just over here on the left, if we look at the image here on the left, are things like sort of haloperidol, trifluperazine, fluphenazine, chlorpromazine, so the slightly older generation of antipsychotics. And if we just look at this table over here, we know that they are also called typical antipsychotics. So their mechanism of action is usually that they block the D2 receptor only. So they go in, they block the D2 receptor entirely. And they're more likely to cause extrapyramidal side effects as well. So we know that that is quite a big consideration when using these medications. And as a result, sort of they're not used so much, at least people, I guess, try to refrain from using them in a clinical kind of environment. And then I guess, you know, you had the birth of these kind of second generation antipsychotics, which are also known as atypical antipsychotics, and their mechanism of action was just a little bit different. So still kind of blocking the D2 receptors, which is the dopamine 2 receptors, but then also perhaps working on other receptors. I know that over here in this diagram, they've mentioned the 5-HT2A receptor, which is a serotonin receptor. So these medications were slightly different. So still had the element of some blockade of the D2 receptor, but then kind of their kind of partial blockade of second generations, a partial blockade of D2 and some blockade of other receptors. So examples that obviously are listed on both kind of images are things like aripiprazole, lurasidone, ziprasidone, risperidone, quetiapine, paliperidone, olanzapine, clozapine, so all kind of medications that we're quite used to. And I guess after the emergence of the second generation antipsychotics, I guess we were more likely to use them because we then did find that they were less likely to cause these extrapyramidal side effects, which were caused directly as a result of entirely blocking the D2 receptor. However, as I'm sure we're all aware, that the second generation antipsychotics, yes, they give you less of the extrapyramidal side effects, which are things like sort of tardive dyskinesia, stiffness, which is dystonia, akathisia, which is restlessness, but they also then come with this increased risk of kind of metabolic abnormalities as listed over here. So you have the elevated glucose, you have the dyslipidemia, the increase in lipids, but then you also get this kind of weight gain picture with patients that are put on these medications too. So we know that kind of antipsychotic induced weight gain can vary from patient to patient. And as mentioned before, we know that it's widely associated with the atypical or the quote unquote second generation antipsychotic. Whilst just doing a little bit of research for this talk, I did find this very interesting image that was from a paper by Caroline Chu Graham, actually. And it was looking at some data from another kind of clinician that they were working on. And they came up with this really interesting graph, which I thought explained things really well. So we know that within almost after someone experiences a first episode of psychosis, roughly what they estimate is that they go on, if put on something like olanzapine or put on a second generation or atypical antipsychotic, they go on to gain at least kind of 12 kilograms over 24 months. So that's 2 stone actually, so an incredible amount of weight. And then actually, as this weight gain seems to be the fastest during the initial period, during the initial kind of initiation of the antipsychotic, but still seems to carry on actually into kind of 36 months and 48 months. So over here, looking from 24 months to 36 months, patients on average were still sort of, their weight was increasing up to sort of an increase of 4 kilograms and then another 3 kilograms later on in the next year, actually. So we know that actually, as this bullet point over here mentions, that the trajectory of weight gain in people with sort of SMI who are on kind of second generation antipsychotics is rapid, but it's also non-linear. So you have that kind of initial period where you get this stark increase in weight gain, but it does seem to carry on just at a slower rate. So I think it's just important for us to bear in mind. And if we look over the space of 48 months, that's, an increase of about 19 kilograms, isn't it? So, which is an awful lot of weight, actually. Just some more stats that I found sort of whilst researching as well was that I think another paper mentioned that within the first year of treatment, up to 80% of people with first episode psychosis, when after started on an antipsychotic, noticed that clinically their weight had increased by more than 7% from their baseline, actually. So it's a great proportion of people who are started on these medications, and often started on these medications after a first episode of psychosis. We also know that, according to the paper that was mentioned, was that more than 50% of individuals, when started on antipsychotics, progressed to kind of being overweight or obese within 5 years of starting their atypical or second generation antipsychotic. And often a lot of these individuals were in the healthy weight category prior to being started on these medications. So again, we can see that actually, this weight gain is then pushing people into the overweight and obese categories. And we know that comes with significant risk again to, your cardiovascular system too. You have the increased risk of sort of heart attacks, strokes, type 2 diabetes, and ultimately kind of contributes to the shortening of life expectancy that we mentioned earlier as well. Again, another really interesting paper by Allison et al. In sort of 1999, actually. I thought it was quite interesting because they went in and they had a look at sort of looking at kind of estimating and comparing the effects of different antipsychotics on weight gain. So they they had one group which was a placebo, and they actually noticed that this group actually had a reduction in weight post initiation, and then various other groups were sort of investigated, with the highest weight gain actually being noted with the group that was on clozapine. So this group sort of had an increase in weight by 4.45 kilograms, actually. And then second, you have olanzapine too. And then you've got sort of other medications like Certindol as well. Just very interestingly mentioning ziprasidone, because actually I did come across some work that suggested that lorasidone and ziprasidone are known to sort of not be as sort of adverse with regards to this kind of antibiotic induced weight gain. So I think that's probably an area that needs to be has been investigated quite a lot. But clinically, I guess, and I'd be interested to find out your point of view. I think I perhaps have never really seen patients on those medications. I've seen the odd few patients on lorasidone or ziprasidone, but I believe that actually this might be more linked to sort of local areas and what's being kind of commissioned and allowed. Again, just to hammer home the point again, that we see that the weight gain is most rapid within the first weeks of people sort of commencing these atypical antipsychotics. We know that this rate kind of plateaus after a period. Another paper suggested that actually, it's for olanzapine, for example, it takes about 4 to 9 months for this rate to plateau, and for clozapine, 42 to 46 months. Some more work kind of suggested that factors associated with rapid weight gain in the initial period were associated with younger age. We know that when children are started on atypical antipsychotics, their weight does tend to increase quite quickly compared to adults. Patients who had a lower baseline BMI, again, are associated with rapid increase in weight gain during this initial period. And they cause an increase in appetite. Another really interesting thing that was noted was that rapid weight gain of more than 5% in the first month after use of a atypical second generation antipsychotic was thought to be the best predictor of his significant long-term weight gain. So actually we know that if patients are going on to gain this weight very quickly at the beginning, it may stay with them for quite a long time, actually. I thought it might be just very useful to put this in. Some of you may be familiar with this diagram, actually. So as part of being psychiatric trainees, we sit exams, and this is actually what we're taught. This is actually from some of the guides that we're encouraged to use. And this is what we're taught about antipsychotic induced weight gain, very much 3 categories of low risk, moderate risk, high risk. So we see that the 2 medications in high risk are listed as clozapine and olanzapine, which we're familiar with. And then you have your moderate risk, including kind of quetiapine, risperidone, paliperidone, and then the rest sort of put into low risk. But I thought it'd be very interesting to mention, actually, from a psychiatric trainee point of view, sort of the resources that are available to us and what's said. Just to explore a little bit further in terms of different mechanisms of different antipsychotics. So I thought it might be quite useful to go through that. So, how different antipsychotics actually affect the body and what kind of leads to this weight gain. So the 5 areas that I'll be looking at are kind of neurotransmitter receptor binding, so the receptors that these antipsychotics work on. The second one will be sort of looking at how the hypothalamic system is affected and dysregulation of that, because we believe that a lot of these atypical antipsychotics cause dysregulation of the hypothalamic system, which then kind of causes this weight gain, as well as kind of peripheral metabolic effects as well, which ties in with the hypothalamic dysregulation. I also did find out that there was a little bit more there's some genetic susceptibility, which I thought would be quite interesting to explore as well. And something that seems to be a little bit more emerging, I guess, from my point of view, would be these some work, sort of a preliminary study that was done around kind of microbiome changes. So changes to the microbiome that may sort of be these antipsychotics or these atypical antipsychotics may be causing within patients, and how this may be contributing to weight gain. So when looking at kind of the neurotransmitter receptor bindings, so I've just tried to keep things quite sort of simple. So we think that it's actually, or at least I've chosen to mention here, 3 main kind of receptors that contribute a lot to weight gain. So if you remember back to one of my previous slides where I showed that actually atypical or second generation antipsychotics act on both D2, which is dopamine 2 receptor, as well as usually another receptor. And the example on the table was 5-HT2C, as shown here, which is serotonin. So just looking at sort of a few of the other receptors that these atypical antipsychotics may work on. So the first being histamine H1 receptors. So this is actually a histamine receptor. And we know that when activated causes sedation, causes weight gain. And what we think how that tends to work is that some of the atypical antipsychotics that act on this receptor can increase appetite by activating parts of the hypothalamic system, actually. So it causes this kind of increase in appetite, which causes people to eat more as a result. So when sort of these people are prescribed atypical antipsychotics, not only are we sort of changing we're kind of changing their chemistry inside, we're changing which receptors are being activated, okay? And then another receptor that I thought would be important to touch on and that is often mentioned is the serotonin sort of receptor, which is 5-HT2C. So this particular receptor is involved in sort of, when activated, disrupts kind of satiety signaling. So again, it's something that we'll explore in the next slide, but sort of how the body's mechanism to register how full it feels. So as a result, when you activate the 5-HT2C receptor, what you're doing is that the body's getting a little bit confused as to how full am I, and as a result may kind of end up eating more, despite sort of eating a normal meal, if that makes sense. And I'll mention POMC in the next slide. And the last one, as mentioned before, was the dopamine D2 receptor, that is often kind of blocked as well, as part of kind of atypical or second generation antipsychotics. So we know that by activating that kind of receptor and by blocking it, you reduce the reward related energy expenditure, you reduce the motivation for activity actually. So this then kind of contributes to some of the weight gain that then occurs too. And then, as mentioned, sort of just a little bit ago, sort of just looking at the hypothalamic system as well, and how kind of disruption to that can cause weight gain, which is essentially what a lot of these atypical and second generation antipsychotics are doing. So in particular, looking at the arcuate nucleus that's just sat over here in the hypothalamus. So we know that it produces POMC, which was something I mentioned in the last slide. Or CART, it also produces CART, which is cocaine and amphetamine regulated transcript. NYP, which is neuropeptide Y, and AGRP, which is a gluten related peptide. So a lot of these kind of substances that are then produced by the arcuate nucleus are all involved in kind of mechanisms that help us kind of helps the body kind of monitor how full it is and whether it needs to eat more. So again, as mentioned here, it helps to kind of regulate kind of eating habits, body weight, and kind of energy metabolism. So if you imagine now that the antipsychotics that we're giving kind of disrupts that system, then essentially what we're doing is where we do have the space to then kind of cause this antipsychotic induced weight gain. Just to highlight that actually POMC and CART are both kind of, I guess they suppress appetite, okay, and that they work by sort of reducing appetite. So in a normal system, what happens is that after these kind of neurohormones are secreted, a lot of the times the secretion of these neurohormones is controlled by insulin, and we know that insulin is produced in the pancreas by the beta cells in the islets of Langerhans actually. And we also know that another thing that controls kind of synthesis and secretion of these neurohormones is leptin, which is produced by adipose tissue, so the fat tissues inside you. What happens is that leptin kind of passes through the blood-brain barrier. It binds to two different receptors, so leptin A and leptin B, in the hypothalamus, and it usually kind of reduces the synthesis of neuropeptide Y and AGRP, which are both responsible for increasing appetite. So if you imagine that you've got leptin coming in, and then it activates the receptors within the hypothalamus, it will reduce the production of the substances, which then kind of increase your appetite, but then increases the synthesis of POMC and CRT, which are used to reduce appetite actually. So essentially what you're doing is that your body's saying that, yep, okay, I've got this leptin, I'm feeling that, okay, I've had enough to eat, and essentially that's how your body controls it. So now if you imagine what happens is that actually the atypical antipsychotics come in and start disrupting that pathway, that can cause kind of missignaling, that can cause inappropriate production of these kind of neurohormones, which can then kind of cause this kind of antipsychotic induced weight gain. And we think that actually, as mentioned in the last bullet point, that the weight gain effect of atypical antipsychotics may originate from deterioration of the hypothalamic regulation system. So I've just tried to keep it simple over here. Another thing that's kind of linked to this hypothalamic dysregulation is that's almost what we would say the central system, so the system that's working in the head, but now kind of exploring the rest of the body, which is the peripheral system, thinking about what other hormones are in play as well. So you have sort of, as soon as we know that taking antipsychotics sort of increases insulin resistance actually. So we know that that's linked with kind of developing type 2 diabetes, which is obviously again going to affect someone's mortality and morbidity too. And we also see this kind of increased release of triglycerides and low kind of denser lipoproteins as well. So from adipocytes, so the not so good kind of fat in that sense. So you've got your dyslipidemia that forms too, which again puts patients at risk of kind of stroke and other kind of cardiovascular diseases. The next kind of peripheral metabolic effect would be kind of dysfunction of the leptin and ghrelin production. So I know that we mentioned leptin in our last slide, but leptin, the way that I try and remember it, is actually the Greek word leptos, which means to mean thin. So we know that that's produced by fat cells as part of the feedback mechanism that we spoke about in the last slide, which is involved in kind of controlling appetite actually. We know that leptin acts on POMC and CRT, and we know that what happens is that as soon as these atypical antipsychotics are used, the levels of leptin may go up actually, okay, which then acts on POMC and CRT. Ghrelin is another kind of key player that we should probably talk about. So it is a potent kind of hunger-inducing hormone, which is produced by the body, and it works by kind of enhancing fat deposition and increases kind of and prompting people to eat more food. So it stimulates your neuropeptide Y and AGR as well. So again, causing the body to eat more. So elevated levels may sort of cause an increase in appetite when using antipsychotics. So again, I'm sure it's something that we've all kind of come across, that actually when someone's on kind of these atypical antipsychotics, they do experience a kind of increase in hunger, and that could be related to an increase in ghrelin actually. And another kind of effect that we've also noted is that, these atypical antipsychotics do have a possible effect on adipogenesis, which is the process of kind of fat cell formation. And we know that it's those fat cells that then go on to produce leptin. So it's almost like everything kind of feeds into each other and starts affecting this one kind of central hypothalamic kind of process actually, which is incredibly interesting. Another key thing I thought that would be interesting to mention would be kind of some of the work that's being done around kind of genetic susceptibility. So apologies, I meant to put the year here for Zhang, but they identified that actually it was a meta-analysis. So they went through and had a look at all of the papers surrounding this topic and looking at genetic susceptibility and antipsychotic induced weight gain. And they found that actually there were 13 SNPs, so single nucleotide polymorphisms, that were identified from 9 particular genes. And obviously, I'm sure you're all aware that single nucleotide polymorphisms just means that there's one of these bases that essentially just changes. Okay, which causes the production of, in some cases, an entirely different protein. Okay. And they all seem to stem sort of from 9 genes. So I've just put an example of 4 actually that the single nucleotide polymorphisms showed the largest effect size. So ADRA2A, DRD2, 5-HTR2C, MC4R. So 5-HTR2C is actually the one that affects the serotonin 5-HT2C receptor actually, and the MC4R is another gene that then affects the receptor, which is one of the receptors involved within the pathway we spoke about previously. So it's all really, really interesting to see how a lot of this is all kind of coming together actually. And I believe there's plenty more work kind of ongoing in this area too. Lastly, when sort of just having a quick look for this talk, it was kind of exploring what else was kind of emerging at the moment in terms of mechanisms that may be driving antipsychotic induced weight gain. And actually there was a very interesting preliminary study done by Howe et al. From 2023 that looked at kind of the gut microbiomes within children actually who were put on children who were on antipsychotics. So one of the theories that obviously is that that atypical antipsychotics modify the gut microbiome and perhaps part of the reason why we see such an increase in weight, or this antipsychotic induced weight gain, is perhaps that it is mediated by the gut microbiomes of these patients. So as I mentioned, Howe et al. Carried out a preliminary study which looked to compare the gut microbiome of basically comparing, you had a control group which had sort of 25 candidates or participants, and then kind of another kind of group that was split in two again. So you had antipsychotic exposed individuals with overweight, or who were overweight, and those were 21 individuals, or antipsychotic exposed but with normal weight, and there were 36 individuals in that group. And what they found actually within their kind of preliminary study was that actually there was a decrease in kind of microbial richness and diversity that was noted within kind of patients who were exposed to antipsychotics when compared to the control group. And they actually found that, especially within the group of people who were antipsychotic exposed but were overweight to start with, they had a higher abundance of particular bacteria shown to be Megnomonas and Lachnospira. So again, just a really interesting finding. I know that I think they've mentioned at the bottom that they would quite like to do some more work surrounding this area. So just an interesting finding to note. I'm sure we're all aware of the long-term impact of antipsychotic-induced weight gain. We know that it causes this development of metabolic syndrome. We know that it increases cardiovascular morbidity, it increases insulin resistance, it increases kind of cerebrovascular morbidity. It can, we know that it can lead to a reduced kind of quality of life, as well as kind of the shortened, or has perhaps a link to the shortened kind of life expectancy we may see. Obviously, we may see. We also know that when people go on to gain a lot of weight, actually, it can cause kind of a reduced compliance to medication and increased kind of non-adherence to treatment regimens, which was very interesting because we saw a patient sort of in clinic last week, and her main concern of being put on quetiapine or olanzapine was due to this kind of weight gain, because she said, she had previously suffered with an eating disorder and was still having these thoughts, and was actually sort of, despite her needing this medication and knowing the good that it might do, was absolutely terrified of the antipsychotic induced weight gain, actually. And just, a very quick diagram, as I'm sure we're all aware of the long-term impact of antipsychotic induced weight gain, sort of when these patients kind of go on to kind of gain a lot of this weight. It can interrupt their sleep, cause sleep apnea. We know that it can affect the liver, so we know that excess fat, so NAFLD, so non-alcoholic fatty liver disease, can also occur, which can then kind of damage the liver too. We also know that it can cause kind of issues with your gallbladder as well, which can then kind of lead to perhaps formation of gallstones too. Kidney failure, again, sort of, I guess, kind of linked from sort of, as well as kind of this obesity, or that can occur sort of linked with kind of the effects of diabetes and high blood pressure as well, can possibly even lead to CKD, so chronic kidney disease, can lead to kind of rashes or some kind of discoloration, joint pain if there's more sort of weight within sort of the structure of the body, an increased risk of stroke, increased risk of heart attack, GORD, or GERD as it's written here, which is gastroesophageal reflux disease, and can also kind of affect kind of fertility too. So yeah, it's I'm sure we're all aware of the long-term impact of this weight gain as well. So just a final slide, just to kind of think about kind of considerations for the future. So I know that obviously Joe and Ita mentioned sort of the work that was done around kind of Resolve, which is how this network, I guess, was formed as a result of some of sort of the findings that were found in Resolve, and then some later work. And I think I recognise some of the names that we've got, a few people that we've met on our online workshops and sort of for our in-person events. So actually thinking about how do we apply the findings from Resolve, and some of those findings were that I think perhaps more conversation needs to be sort of started around counselling patients when antipsychotics are started, and sort of what kind of key pieces of information should they be provided with. I know that Ita's also mentioned that next month's talk is kind of thinking about the medication side of things. How do we manage antipsychotic induced weight gain? So I've just put the role of metformin for now, and sort of I know that she mentioned that she'll be talking a lot about GLP-1s, which is going to be exciting. And another kind of key finding that obviously we found was that a lot of these interventions were enacted kind of after the weight gain, and what can actually be done within this sphere to think about how can we put in any preventative measures, which was a lot of the work that, you know, we had those conversations and the online workshops and the in-person day at Aston in March. So what can we do to kind of change that for the future, I guess would be my question. But yeah, I think that's everything. I think I finished a little bit earlier than expected, but I hope that's okay. I've just left my email there for anyone, should you want to contact me.
Jazz, that was fantastic. So for those of you who don't know me at all, before I came to mental health research over 3 years ago, I spent 12 years working in stroke. So I have been on the learning journey of my life in respect to especially antipsychotics, pronunciations, and all the things. I wish I'd had this when I first started. It would have made things so much easier. You might be able to see just behind me my copy of the BNF is a very old one, but it is mainly because I couldn't spell anything. So Jazz, thank you so much. That was really, really insightful, and I've certainly learned a few things as well. And I did have a little bit of a grin when you mentioned ghrelin, because obviously I think we've had that discussion. So for me, for quite a few months, it was leptin and the gremlin hormones, because I couldn't remember the names of them. So if anyone has any questions they want to ask in relation to any aspect of this talk, please write in the chat. If not, I'm sure that we can continue the conversations anyway. But thank you so much. Ita, is anything you want to add?
No,
Sorry
I
to put you on the spot with your cold.
No, you're okay. I don't think so. It's interesting listening to, and perhaps this will give people time to write questions if they have them. Listening to the mechanisms that comes up a lot around what causes antipsychotic induced weight gain, etc. And it's important as scientists and as clinicians that we're aware of that. But something I find really helpful, and I don't know if Jazz, in your conversations with patients or service users, if you feel the same, but I think something that's really helpful to remove some of the shame that can come with managing this, and the messaging that we traditionally have given all people really living with obesity, but especially obesity due to antipsychotic medication, is that kind of cumulative effect essentially is that the messages between people's stomach and their brain that you or I have when we don't take these medications is essentially kind of broken or has been hijacked. So for a person who's taking antipsychotics, because of the interference with that kind of hypothalamic appetite control through various mechanisms, it seems, people don't get the same hunger messages that you or I would to say that we've eaten enough food. And that means that people don't get the same satiety from food, but also that they crave more food because their body and their brain literally doesn't know that it has enough food in their system to meet their energy requirements. And I even think of my own PhD when we did some qualitative research around this. I think that's really important to almost share that mechanism with patients sometimes, because it validates their experience of, I've really been trying walking, swimming, running, etc., and I'm still just so hungry. That's normal, particularly for people who are impacted by increasing severity of weight gain, or if they're taking high risk medicines. And that's really how the metformin works, particularly if you use it earlier, is to kind of re-establish that link between the brain and the stomach that actually allows you to turn down those hunger drives and allows people to control their appetite much more readily. But it really does, I think, when we understand the mechanisms as well, explain the futility of many, and if not all, dietary and lifestyle interventions in managing antipsychotic induced weight gain. And it's why either prescribing lower risk medications or looking at greater or more systematic use of metformin among people who are very likely to gain weight from antipsychotics actually is going to be the way of the future if we want to address this particular cause of obesity among those living with a severe mental illness in a systematic but also in an equitable way. And that's really important because people can access metformin readily because it's obviously cheap, it's generic, etc. Whereas we're going to run into a much bigger issue with the GLP-1 agonist, which we'll cover. But that's just some of my additional thoughts.
Thanks, Isa. So we've got a couple of questions that have come up in the chat. So the first one's from Kerry Harrison. So if we read it out, but Kerry, if you want to ask any follow-up question, if you turn your camera on, then we'll be able to do that. So Kerry wants to know if there's any evidence about the links between antipsychotics and the craving for sweet, creamy food and greasy food. She's read it and wonders whether it's anecdotal or evidence-based. I think it depends. I mean, I don't know what you think, Jazz, but I think it would depend on is the quality of the evidence that you have. So all of these studies are generally, my brain's just gone dead, self-reported over what people are eating.
Yep.
So there is that element of it. I mean, I think then there's obviously the observational stuff, but I've also been to obesity conferences where they've broken down the chemical pathways involved in obesity outside of antipsychotic medication, and they've identified which are the particular structures that are involved in the cravings for sweet foods and greasy and carbohydrate heavy foods, and they are usually implicated in obesity. So I don't think that research has been replicated with antipsychotics as yet, but I don't know what else you know about this field. Jazz, Anita, I don't know if you've looked at this either.
Yeah, I don't think I've come across any studies in particular looking specifically at kind of the use, or I guess the role of kind of sweet and creamy and kind of greasy foods within kind of patients who are on antipsychotic induced weight gain. But I think, just to echo what Jo said, I think we already know sort of people who aren't on antipsychotics anyway do experience kind of more craving for food, eat more if they're snacking on sugary and greasy and carbohydrate rich food anyway. So it's often, we know that things like crisps and things like chocolate anyway and sort of sugary snacks will often kind of affect some of the hunger drivers, from what I remember, and will cause people to be hungry. And these are people sort of a lot of, I think the work I was reading about is, you know, people who aren't on antipsychotics. So I imagine if there's already kind of some disruption there within patients who aren't on antipsychotics, I imagine that people who are on antipsychotics perhaps obviously feel it too, and perhaps maybe feel it to a greater degree. I wouldn't be able to say for certain, unfortunately, but I have anecdotally heard the same. Yeah.
I'm sorry, it's hay fever season and I'm not quite talking properly, but I can also speak from our research. So we've interviewed a lot of people with lived experience, and one of the things they talk about is this insatiable craving or hunger associated with particular food groups, and they can go and they can eat something else, but they still have the craving. And what was helpful for me was to disaggregate hunger and cravings. You can not hungry, as in you can have eaten enough but still crave the piece of chocolate cake or donut or whatever it is, or packet of crisps. And that, I think, was helpful for me to just sort of think about that, because then we can maybe look at some of the more psychological mechanisms to be able to help deal with cravings, but only if the hunger driver has been satisfied. Ita, do you want to come in?
Yeah, I think it's not that we need direct evidence for that. As you said, it matches with our clinical experience. It's exactly what happens. Think if you get a poor night's sleep and you wake up the next day and you're craving high energy, high sugar foods for energy. Again, your brain thinks that you are starving a lot of the time when you're on antipsychotics. So your brain will naturally send messages to you to crave higher energy or energy dense foods like high carbohydrates, fatty foods, etc. So that's why people eat more portions, but they also say I tended to go for higher energy foods, because they literally are trying to meet their energy requirements or satisfy that drive that's coming centrally from them. So I think we're looking at it in the wrong direction. It's essentially that provides us with more evidence of what we know about those central effects of antipsychotics on the brain in terms of managing our appetite.
Great. So the next question is from William Edwards. So is there any links about antipsychotic medication and addiction? And if so, what measures or therapies can be put in place to assist in the weight management for people in mental health? I've completely messed that up, so you can read. But I haven't looked at any. I haven't come across any addiction. I haven't done that crossover, so I don't know if you have, Jazz.
I think from a clinical point of view, and I guess this is just my clinical experience, so is unique to me, I've not come across any antipsychotics that we would say quote unquote are addictive. So whereas, you know, within psychiatry or within mental health, you know, you do have a different group of medications such as benzos, so benzodiazepines, so things like your lorazepam, your clonazepam, your those kinds of medications, yes. You know, zopiclone as well, I guess, is one of them because it's one of the Z drugs. Those are addictive. You know, they can cause addiction when put on kind of long-term use. However, I'm not particularly aware of any kind of antipsychotics that are addictive, actually. I think perhaps, you know, they don't really work in the same kind of mechanism as benzodiazepines from my point of view. However, I guess the only thing kind of I have noticed is that perhaps certain antipsychotics are preferred more by certain patients, because we know that things like quetiapine can really, really help with your sleep. So we know that, you know, that there are instances where perhaps maybe that medication is more useful in that sense. So, however, I'm not aware of any kind of addictive properties, at least, of these medications.
Yeah, each of you got anything to add on that from the stuff?
Yeah, definitively antipsychotics. There's no evidence to support that they meet any of the criteria for physical or psychological addiction. The only psychotropics that do that would be benzodiazepines or Z drugs. I wonder, does this person mean food addiction? Just in terms of the topic.
William, would it help if you
discussing?
turned on your camera and added a little bit more?
Either way, there is not for food addiction either. So no, antipsychotics are not addictive in any way, shape or form.
Interestingly, one of the patients, or one of the people with service users that I interviewed for our research did actually use, I can't remember the name of it, but it was like a food version of Alcoholics Anonymous for them to be able to help with their weight gain. But this was several years post initial weight gain, and they found it helpful, but they were the only person that I'd come across like that, and I'd never even heard of the organization. I can't even remember the name of it now. But whether or not it was a food addiction or whether it was a way of them being more mindful about what they were eating, that bit I think is a bit unclear. So it could be that there are lessons to learn from other areas of healthcare. So in terms of managing weight gain, ETA will obviously cover GLP-1s, and we've already discussed a little bit about metformin, so we've got that from a pharmacological perspective. From a non-pharmacological perspective, the evidence is mixed, to say the very, very least. There are some trials that have shown very small improvements. Sometimes something that is statistically relevant is not very clinically meaningful. So sometimes people have lost like a pound or two, but they've put on, say, 5 or 6 stones. The trials that have had the most, I suppose, effect are those that are multimodal. So those that combine diet, exercise, psychoeducation, support, peer support, you name it. The more components you can put in to support that person to help manage, then the greater likelihood is that you will see some difference during the time period of the trial. And one of my biggest concerns with the non-pharmacological interventions that are being conducted in this area is the fact that there's very rarely a follow-up. I think in our review that we did, I think we found 1 long-term follow-up. However, having put all of that into like a box, if you like, the place that has the most success at the moment with this are the Keeping the Body in Mind study from Australia. So if anybody wants to have a look at what they're doing over there, then that is certainly worth a while. There's really, really interesting stuff that's going on there. And they start preventatively. They have whole clinics just set up to support people with people on antipsychotics with their physical health. So it's not just their weight gain, it's a more holistic approach. So very different. And again, that's probably a better way to approach this. I think more holistic is better. And I've also had feedback from our lived experience advisory group who've been on our research, who've advised that, you know, when they are first coming out of hospital, they may not have accommodation, or if they've got accommodation, they haven't got a cooker, they haven't got any furniture, they don't have any food, they've got to get benefits. The weight gain caused from the antipsychotic, that is the thing that is keeping them currently stable and has been able to allow them to be discharged from hospital is so much lower down their list of priorities when they've got their basic health and safety needs to be able to take care of first. So I hope that helps, William, but if not, please continue any discussions over in the JISC group. All you have to do is email the JISC group itself. I think it's MHII. I'll get the email address and add it in. So if you're a member, you just email the group and it will send an email to everybody else. So Erin has asked if we offer any webinars around this related to children and specifically young people. So this is a great thing because Isha and I were just talking yesterday. What we would like is for you to let us know what you would like us to cover in these webinars. So we've got 2 webinars coming up in September and October that are focusing on forensic settings. Then we've got one in November, which will focus on primary care and the role of the carer, but to care for people's physical health within primary care. And then in December, we've got Ed Beveridge and Claire Jones from the Royal College of Psychiatrists coming on to tell us about their new report, which is coming out. But currently we have 2026 free. So if you have any requests for things that you would like us to try and find speakers, or you would like topics covered, or you have speakers that you would like to, mention to us, let us know. And we will try and do our best to get somebody to satisfy that in 2026. So Erin, I hope that helps. But if I've misunderstood, please let me know. So are you aware of any research into long-term weight gain for service users who have been on treatment for many years? So most of the research that I've come across is exactly that. It's people who've already gained the weight. There's very little research, there's very little evidence at all preventatively. And it's from a non-pharmacological perspective, I would be sitting on the fence. I haven't really found anything apart from the emerging results that are coming out of the Keeping the Body in Mind study. I don't think there's much evidence to say that the current interventions can be helpful. Ita, do you have anything to add on that? Because I know you've done quite a lot in this area as well, but more on the pharmacological stuff.
I would say that the longest studies would be cohort studies. There's some better quality prospective ones published in Spain not so long ago, and they would be more realistic weight gain estimates as well. When someone asks you about the average kind of weight gain, it's a problem sometimes with the medicines information that we give to people when it talks about average weight gain estimates with olanzapine or something like that, that it comes from a 6 weeks randomized control trial, which is an issue when that doesn't reflect the typical duration of treatment. I can post some of those in the chat, some of those studies, if people are interested in looking at them. The one I'm thinking of covered a 3-year period. So I can put that in, and I see Gareth has a paper on mechanisms. We actually published one in relation to metformin that covered the mechanisms specifically of antipsychotic induced weight gain and how antipsychotics interfere with the hunger drive stuff. So I'll put that in the chat too, just so we don't go back over the same things again if people have other questions we wanted to get to.
Brilliant. Thank you. So we've got a couple of minutes left. So if we have anyone else that wants to put a question in the chat, that would be great. And again, if you've got anything that you think you'd like to know more about, this is not just around antipsychotic related weight gain. This will have a broader focus on physical health as well. And again, for different settings. So like Erin's mentioned, child and family settings. So we're potentially looking at CAMS, and we'll try and see if we can find someone. I think I might know a pharmacist that specializes in CAMS. But we can try and see if we can organise that for 2026. Again, if you know of anybody, send them our way, because it's always helpful to be able to get recommendations for these as well. So if anyone wants to say anything, please do so. Our next, Lauren, can you just re-advertise the link for the next chat? I have just had a look at the JISC mail, and some of you have just signed up. So we have gone from 0 to 97 members in about 3 weeks, which is absolutely fantastic. So hopefully this will be a network that you can use to learn from each other, and we'll see you next month. But thank you very much for attending. We really appreciate it.